So hope you are well awake, because I will bring you on a journey of my journey on neonatal seizure approach from an epileptological point of view. The majority of seizures in neonates are occasional seizure, and as we saw that neonatal brain react with seizure to a variety of acute insults. However, a significant percentage of seizure in neonates are the first symptom of epilepsy that can be already diagnosed in the neonatal period, and these will support the choice for a long-term treatment. In some cases, seizure can be seen as one of the signs of a seizure syndrome in the newborn. So this is very important, and we will start our journey by saying that not everything that shakes is epilepsy. So when you see a movement, a funny movement in the newborn, first question is that an epileptic seizure? So second question is this just an occasional seizure, or we are in front of the neonatal onset epilepsy, which is very different. Can the sign, the electroclinical complex of sign, can define a neonatal epilepsy syndrome? And defining a syndrome will allow us a greater precision on diagnosis and prognosis. So is that an epileptic seizure? This is easy. This is a movie I did in 1993. I was very young. By then, everybody knows that this is just tremor, jitteriness. This is not an epileptic event, and you know the difference between semiologically between a myoclonic jerks, who has a fast phase followed by a slow phase, compared with the tremor, who is the same movement around a fixed axis. And everybody knows that this tremor can be modified just by changing position to the baby or constraining the limb or the heart. Jitteriness can be found in normal newborn as well as in newborns with hypoxic ischemic encephalopathy, metabolic disorders, and with this does it means that they are epileptic. So this is easy. You see these babies having tremor, EEG is normal, no correspective of EEG discharge, you change the position and the jitteriness will disappear. Sometimes it's not that easier. And this is a baby that was brought, this is in San Francisco, and he was in the NICU because the mother noticed couple of days after birth, these movements, this funny movement that actually semiologically, those are real myoclonic jerks. So these are clonic jerks, bilaterally involving the four limbs, rhythmic. So what is this? So this baby had a full EEG recording. And we found this is an EEG. So you have two on the left, two derivation on the right, left and right, left and right. And you can see that this is a quiet sleep with what we call tracé alternance. So there is an alternation between higher amplitude mixed features and followed by a lower amplitude brain activity. And you can see those are the jerks, and there is no epileptic activity on the EEG. And if you look at the same baby, couple of hours later, is still sleeping, is a newborn 2 days old, and there is no movement. But the full video EEG recording continued to go, and again, so this is what you saw is an active sleep. So an active sleep has a low amplitude activity very similar to the awake sleep, and those are the artifacts to the jerks, and there is no epileptic activity. But still, those are myoclonic jerks. And if you continue to follow the recording, again, the baby continue and start to present again with these myoclonic jerks that are quite impressive, that involve both lower and upper limbs that are rhythmic. Are those seizures? This is a benign neonatal sleep myoclonus. Healthy newborn, familial occurrence. The onset is within the first days of life, and it is characterized by repetitive myoclonic jerks of the extremities exclusively during quiet sleep. EEG is normal ictally and interictally, but most important, if you want to do the diagnosis, and you can just wake up the baby and the baby will stop, or when the sleep will change from quiet sleep to active sleep, also the myoclonic jerk will disappear. So diagnosing seizure in the newborn is difficult, if you want to do the right diagnosis, of course. Healthcare professionals, they have this difficulty in discriminating clinically between neonatal seizure and non-seizure movements. And actually, this is a very nice study that is published on epilepsy in 2009, and they show videos with epileptic and non-epileptic events to both nurses and doctors in pediatric neurology and neonatology. And as you can see, the average number of correctly identified events was 10 out of 20. And more importantly, doctors were not doing much better than nurses. So this is the revised terminology of the International Leagues Against Epilepsy that has been published in 2009. And this makes a big change regarding neonatal seizures. So neonatal seizures are no longer regarded as a separate entity, and they need to be classified with the classification of seizure and epileptic events. More importantly, electrographically documented neonatal seizure with or without clinical manifestation represent the most accurate and current concept of neonatal seizures. Sorry. Also, another difficult thing is when a baby, this is a baby, cooled baby with severe hypoxic ischemic encephalopathy. People are around him, so people are taking care of him, and there is no movement, absolutely nothing. He is having a cardiac ultrasound, and for the whole day long, and the days he was cooled, he didn't have any spontaneous movement, nothing that can suggest that this baby was seizing. In San Francisco, we monitored this baby continuously with CFM, so amplitude integrated EEG, and full video EEG. And this baby actually was having a bilateral status epilepticus that was going on for hours. And all this status epilepticus was absolutely subclinical. Now, you are a neonatologist, same for pediatrician and child neurologist. It shouldn't be difficult to distinguish an intelligent child with benign focal seizure, such as in Rolandic epilepsy or childhood absence epilepsy, from a child with Rasmussen encephalopathy, Lennox-Gastaut syndrome, or catastrophic progressive myoclonic epilepsy. Now, just defining all these children just by saying they have epilepsy doesn't offer more advantages than saying that a child has a febrile illness without any, irregardless to cause. That could be a mild viral illness or a life-threatening bacterial disease or a malignancy. So children are different, and we don't talk about epilepsy, we talk about epilepsies. Neonatal seizures are still considered as a whole, but they aren't. And early distinction between occasional, single, or isolated seizures and neonatal onset epilepsy or neonatal onset epilepsy syndromes has important therapeutical and prognostic implication. You learn from Joe Volpe and many others about the classification of neonatal seizure. And you learn that neonatal seizures can be clonic, tonic, or myoclonic, or they can have a motor automatism and other uncommon manifestation. This is the classification of neonatal seizures. As an epileptologist, I would like to invite you to move from the classification of neonatal seizure to the classification of neonates with seizures. So first of all, let's talk about those babies who have occasional seizures that do not require the diagnosis of epilepsy. This is a baby in San Francisco. It's a girl, 6 hours old. She was born no problem. She was brought in the nursery, in the room with the mother, and then both mother and nurse, they noted these myoclonic jerks over the left limb. And you need to pay attention to that because this is a movie and you are staring to that, but the baby is small and the limb of a baby is even smaller. And to notice this movement may not be easy. So if a nurse calls and say, I saw some funny movement, I would say, stay a little bit by to the crib and see what happened, because those are focal myoclonic jerks. Seizure is pretty long, as you can say. You can see that the involvement is quite limited, is only confined to the left upper limb. So it's very much confined. And this tells you a lot about the future outcome and what you will expect to find on the MRI. And this is the EEG. You can see that the background is really not bad. You have a good brain activity, good amplitude, pretty much symmetric, although over the C4 region, so over the right central region, you have a seizure that just started, and you can find it on C4 here, and here, and here, these repetitive rhythmic spikes. The seizure is long, so in the beginning there is no clinical manifestation, and then the seizure will continue with left arm jerking, as you saw in the video, and again. So the seizure is pretty long, but even on the EEG, it remains very much confined over the central, right central region. And here is the MRI. This was a stroke, very focal, very limited, very confined to the right central region in this baby. This is a hypoxic ischemic encephalopathic baby who has not been cooled. This was in Rome. And we have been called and we performed an EEG for this funny movement that you can recognize easily. This is jitteriness that's very common in asphyxiated baby. So you can see these are the movements. This is a more fine jitteriness compared with the gross jitteriness you saw in the other child. So this was the first day of life. But on the second day of life, neonatologists called again and they said, we saw something. And neurology said, we did an EEG yesterday. Those are tremors. This is not a seizure. But actually, we got an EEG again because they were really convinced that it was a seizure. And so if you look at the baby, this is her breathing frequency. And then you can see how the frequency will change and the child will start to hyperventilate. And you can see here, you have the hyperventilation. So this was the same baby 24 hours later. He was having tremor and jitteriness, but here, this is not tremor nor jitteriness. So the child will open the eyes, and if you can notice, there is an eye deviation over the left side. Over the right side, sorry. So you see, open the eyes. And then the motor seizure will start with the tonic posturing, hypertonia of the upper limb and the left arm and leg. And then the seizure will involve more areas. And this is a typical tonic posturing seizure in those babies. This baby is very different from the healthy baby with a small stroke, right? So those are different babies, not only different type of seizures. and then she stops crying, and you will see she will start on the same size where she had the limb hypertonia. She will start to present with clonic eye jerks. There is no blink reflex. There is a tonic turn of the head over the right side. She hyperventilates, and the technician calls the neurologist quickly. And you see the clonic jerks over the left eye. And this is the EEG. So the EEG is quite different. It's very different. Those two babies, the one I presented you before and this one, they have seizures, neonatal seizure. But this one has a background that is low amplitude, very much is not organized. And here you have the seizure that starts over the frontal and central temporal region over the right side. In Europe, and especially in Italy, we start to record from right to left. In the US, they start from left to right. We would not be able to find an agreement, but anyway. So this is from left to right. We should always record the baby with polygraphy, so with muscle, and EOG and PMG. So you have here the seizure going on. Then you have the left limb hypertonia, the left arm hypertonia. You see all this movement artifact, but you can see the seizure is still going on over the right side, and she was actually having an eye deviation over the right side, but the seizure was clinically left-sided. And here is when she starts to crying and clearly hyperventilation, and you can see here on the PMG. And this is when she stopped crying and she has the left eye jerks. So it's a pretty long seizure. And this is the MRI on day 2. So we got an MRI even if this baby was not intubated, so it didn't look so much to have a severe hypoxic ischemic encephalopathy. You see the damage on the basal ganglia and over the parasagittal areas. I cannot say if this is mild or moderate, but this was a damage on the basal ganglia, and this was the MRI on day 25 with the multikystic encephalopathy. Sometimes you have, so those two neonates have neonatal seizure as a response to an acute event. You can treat those babies with low, maybe for the first week or the first 2 weeks, short-term treatment, because you know that, first of all, phenobarbital will not protect them for having a West syndrome, and you know that most of them would not have epilepsy, so seizure will not recur. So you take a wait-and-see attitude. But then you have some babies that starts their epilepsy, and epilepsy is a chronic disease. They start their epilepsy in the neonatal period. This was a baby, now 28 days old, that came to us because she was having focal seizure, treatment-resistant, treated first with midazolam, then phenobarbital, then phenytoin, and she was continuing to present these seizures despite all treatment. This is a focal seizure, so the baby will turn her head over the right side, and then she will start to have, here you have the EEG over the left side, spiking and rhythmic spikes, and then the seizure will become bilateral. And I don't say generalized because, as you can see, those are asynchronous bilateral myoclonic jerks. So as you can see, it's not this, as we are used to see in generalized seizures. This is more like this. So this bilateral asynchronous myoclonic jerks. This baby was treated with benzodiazepine, phenobarbital, phenytoin, and she was resistant to everything. In 2003, we had no Keppra. But anyway, look in the same recording what happened. After the focal seizure, the baby starts to present at 1 month old infantile spasms. And you have here the spasms that are asynchronous. See? So the babies have contraction of the upper limbs, and you have this infantile spasm correspondence on EEG. So you have focal seizure, you have infantile spasms. Would you put this baby in the statistic for neonatal seizure outcome? No, you won't, because this baby doesn't have neonatal seizures. This baby has a neonatal onset epilepsy, and particularly she has an Aicardi syndrome, which is malformation characterized by a genesis of the corpus callosum, and you can see the rectilinization of the ventricles and defect of the retina, lacunae, chorioretinal lacunae, but clinically is characterized by focal seizure plus infantile spasms. And the only drug that works in this disease, in this kind of epilepsy, is Vigabatrin. So you know that this baby will need Vigabatrin from the beginning if you want to try to have her seizure-free as much as you can. This is Aurora. She was born at term on July 23, 2009. No family history of neurological disease, but she has a prenatal diagnosis of cardiac rhabdomyoma. She was born fine, no seizure clinically observed, but we know that cardiac rhabdomyoma rhymes with tuberous sclerosis. Tuberous sclerosis is a neurocutaneous syndrome characterized by the presence of hamartomas in different places of the body, in the heart, in the kidney, and in the brain. And what we also know, we know that cardiac rhabdomyomas rhymes with tuberous sclerosis, and hamartoma rhymes with very difficult to treat epilepsy, rhymes with very highly epileptogenic lesion. So we got an MRI the next day, and we found the characteristic lesion that are periventricular small hamartoma and a huge hamartoma, what we call tuber, over the left parietal region. So we know that this is highly epileptogenic. No clinical seizure, but we want to get an EEG. And so 4 days later, she got a full EEG. And on the full EEG, you can see she had several repeated subclinical sequences, subclinical discharge, subclinical seizure, starting over the CA3 region, so starting from this parietal hamartoma that we knew was epileptogenic. And she was started on Vigabatrin. 2 months later, she presented again, this time with clinical seizure, right hemiclonic focal seizure with prolonged postictal hemiparesis. But as you can see, this is the previous one was a neonatal montage, so we don't usually put the parietal leads, but here you have the parietal leads, and you can see that the discharge will come more precisely, accurately from the left parietal region, left central parietal region over the left hemisphere. So carbamazepine is associated to Vigabatrin. So what we learned up to now, we knew this was highly epileptogenic, and now we know that it's treatment resistant. Because if you fail the first drug, you have 30% of chances to respond to the second and 3% of chances to respond to the third. At 3 months, after she had been seizure-free on carbamazepine and Vigabatrin for a month, she started to present with focal seizure and asymmetric epileptic spasms. She was 3 months. We started her on a CTH, spasm disappeared, but focal seizure were still there. At this point, she had frankly a right hemiparesis and a developmental delay. She was having about 50 seizures per day on a long-term monitoring. Most of them were very subtle. So this is the EEG on October, and she was having focal seizure, as you can see here, always starting from the P3 region. Same seizure she was having as a newborn. So the seizure on the P3 was still going on, and here you have a cluster of spasms. This is the polygraphy right deltoid, left deltoids, and you see the cluster of cyclic spasms after just following the focal seizure. At 6 months, Aurora was still presenting the same focal seizure she was having as a baby. Seizures were very difficult. You can see these clonic jerks over, these clonic jerks toward the right. Here, she was having clearly an hemiparesis. At 7 months, so 7 months later, we put her on electrocorticography, and we had epilepsy surgery. She was operated on at 8 months of age with removal of left side parietal hamartoma. Aurora is seizure-free since surgery. She catch up pretty much of her psychomotor delay. She has the right hemiparesis that didn't worsen after the surgery. These early diagnoses changed definitely our approach. If we do not consider that she has a neonatal onset epilepsy that was treatment resistant from the beginning, she would probably have arrived to surgery at 6 years of age, as usually happens. And this is her EEG after surgery. There is even no more epileptic activity over this side. Last, we have the epilepsy syndrome. Epilepsy syndromes are electroclinical entities. Those are distinctive clinical entities that we should be able to recognize on the basis of a complex of electroclinical characteristics. So this is a very well-defined group of diseases. Characteristics can be on age at onset, specific EEG characteristics, that's why we say electroclinical syndromes, and seizure type. The diagnosis of this syndrome has implication for treatment, for management, and for prognosis. In the neonatal period, the classification of the ILAE of 2001 recognizes 4 epilepsy syndrome: OHTAHARA syndrome, early myoclonic encephalopathy, migrating partial seizure in infancy, which is considered and labeled as a syndrome in development, and benign familial neonatal seizure. The first 2, OHTAHARA syndrome and early myoclonic encephalopathy, are also known as as epileptic encephalopathy with suppression burst. This is another epileptology concept that I would like to share with you. What is an epileptic encephalopathy? An epileptic encephalopathy is a condition in which the epileptiform abnormalities themselves, so not only a seizure, not only the seizure, are believed to contribute to the progressive disturbance in cerebral function. It means in the epileptic encephalopathy that if you are able to cure the seizures, this will not bring benefits to the baby because the encephalopathy, the epileptiform abnormalities themselves contribute to deterioration. So they are called epileptic encephalopathies with suppression burst. Suppression burst pattern is very well known because it carries a bad prognosis. It is characterized by bursts of high voltage activity that can last from 1 to 10 seconds, and there is no age-appropriate activity. And they alternate with periods, so the suppression, of marked background attenuation. The characteristic of burst suppression pattern is that this is persistent throughout the whole recording, and is not altered by exogenous or endogenous stimuli. This is a burst suppression in a baby which is awake. You can see all these muscular artifacts. And you can see this is the brain. And I would like to ask you if somebody knows what is the neurophysiological significance of burst suppression. So why this brain starts to act as burst and then suppression. Why burst suppression carries this bad outcome? Because neurophysiologically, burst suppression means that the cortex is dead. The cortex is very much impaired. And the suppression is the cortex, is the expression of the cortical activity. But then you have the thalamus, so the subcortical region. And even though the cortex is silent because it's suffering very much, 30 to 40% of thalamic cells continue to fire. And they have an intrinsic pacemaker properties. That's why you have these bursts that are quite rhythmic. And volleys from these thalamocortical neurons will give this cyclic wave burst over a cortical background that is depressed or totally flat. Where do you see burst suppression? Severe anoxic ischemic encephalopathy, barbiturate anesthesia, gross brain malformation or metabolic disorders. So any condition that will impair massively the cortical function. The difference is in barbiturate anesthesia and hypoxic ischemic encephalopathy, this impairment is transient. Whether in our epileptic syndromes, this impairment is persistent. So we have this characteristic, which is the burst suppression EEG. OHTAHARA syndrome is an epileptic encephalopathy with suppression bursts described by OHTAHARA in Japan. The onset is often within the first 10 days of life. The main seizure pattern is tonic spasms, which are spasms that are somehow more sustained than the usual infantile spasms. It is associated with suppression-burst EEG pattern during both waking and sleep states. Severe psychomotor retardation, poor prognosis. Vigabatrin may improve the condition because this condition is often due to cortical malformation, and Vigabatrin works very well in cortical malformation. And the babies that survive will usually progress into West syndrome. This is a 13 days old girl that was presenting with this manifestation from the first 2 days of life and continued to do this while she was awake. Those are asymmetric infantile spasms, more sustained, so those are tonic infantile spasms. And you can see this is the EEG. I will show you better later. There is a much more expression of the burst over the left side. And contralaterally, the spasm is more pronounced over the right arm. This was the baby awake, and this was the baby asleep. The EEG is exactly the same, is unchanged, is a burst suppression. The only difference is that there is no spasms during the burst. So this is her EEG at 16 days of life that you just have seen. So you have the bursts that are more pronounced over the left side of the brain. You have the infantile spasms that are more evident over the right deltoid, so they are asymmetrical. And this is the wakefulness, so the same baby at 52 days of life. The EEG is absolutely unchanged, and this is the sleep at 52 days of life. And this baby at the left side, it's hemimegalencephaly. OHTAHARA syndrome is mostly associated with brain malformation, such as you have just seen hemimegalencephaly, focal cortical dysplasia, extended cerebral dysplasia. However, in some cases, MRI does not disclose any brain lesion, and in those cases, you have to think about genetics, because very recently, genetic association with STXBP1 gene mutation that stands for synaptic binding protein 1, which is a molecule that is important in neurotransmission. So if this molecule is missed, the cortical neurotransmission is impaired, and so you have the burst suppression pattern. Or also the ARX gene mutations, which are usually found associated with West syndrome. So if you have OHTAHARA syndrome and no MRI pathology, then think about genetics. Early myoclonic encephalopathy has the onset in the neonatal period, so is another neonatal encephalopathy with suppression burst, and sometimes the onset is within the first days, the first hours of life. This is the worst epilepsy syndrome ever in all the life of an individual. The child is already hypotonic and poorly responsive. So please, when we think about neonatal seizure, think about neonates with seizure, and these neonates are different. The baby with stroke was awake, was not intubated, was doing well, and he had focal seizure. These babies are very much hypotonic and poorly responsive, consistent with an encephalopathy. Burst-suppression EEG pattern, but what is very characteristic is the myoclonus. They have erratic segmental myoclonic jerks that involve, sometimes are more massive, and they can involve limbs, eyelids, and different segment of the body, the face, the limbs, and only late they can present with focal seizure and infantile spasms. This baby has virtual absence of development. No treatment so far has been proven effective. ADS, all kind of drugs, steroids, ACTH, and even ketogenic diet is not effective. So this is the worst epilepsy syndrome ever in the life of an individual. So this is a baby, it's a very different baby from the others. So this is a baby, 3 days of life. You can see the poor, very poor burst suppression EEG. I will show you better. And if you pay attention, you will see very small, fragmented myoclonic jerks involving once the extremities, once more massive over the trunk. But you have to pay attention, and again, showing you this video, by showing you this video, I hope you will stare and spend some time looking at this baby instead of just labeling with neonatal seizures. So if you can see, so you had one here and then one here, and sometimes you have more massive jerks. Those myoclonic jerks are continuously, the baby continuously present with these myoclonic jerks all day long. You see one here and here. They are very small, so in order to record them, you need a polygraphic EEG recording. You need to recognize this baby because myoclonic rhymes with metabolic disorder. And this is a massive myoclonic jerks. We have a lot of rhymes in epilepsy. So this is the EEG, and you see the chest respiration, nasal respiration, right hand and left hand. And you can see the very poor burst suppression with very much suppressed interburst periods. And you can also notice these small myoclonic jerks that happen during the burst. Actually, almost everything this baby does is during the burst. These are the respiration, and those are the small amplitude myoclonic jerks over the right hand, over the left hand. And you can see that he breathes during the burst, but even doesn't do much during the suppression period. Early myoclonic encephalopathy is very important to recognize because there is a familial recurrence. So those families, if you make a good anamnestic history, they may have other babies that died in the neonatal period. Is associated with metabolic disorder, non-ketotic hyperglycinemia mostly, and why? Because glycine, together with GABA, is the most important inhibitory neurotransmitter in the brain. And so if you have hyperglycinemia, your cortex is flat, your cortex is not working, your cortex is inhibited. Methylmalonic or propionic acidemia, unrecognized pyridoxine deficiency can lead to this. MRI is usually normal, and unfortunately, in most cases, no inborn error of metabolism can be identified, but you have to look through it. And then I will share with you the story of these twins. Twin girls born at 37 weeks gestational age by IVF. The liver was perfect, Apgar very good, normal neurological examination up to day 2. When twin A began to have some spells with abrupt apnea and desaturation, remember that apnea without bradycardia can be a sign of seizure. Decreasing to the 60s, the saturation within seconds. Interictal EEG was basically normal, and she received phenobarbital and no more episodes. And then on day 5, the twin B began having identical episodes, which responded very well to phenobarbital. Everybody was happy up to 10 days of life when these twins start to display a new type of spell, and they were recorded. So this is one of those seizures. And you can see the baby start to have a tonic posturing. The baby is not intubated, no IV lines, is eating by himself, tonic posturing with hypertonia over the left side. Head is turned over the left. There is as the saturation, apnea. She becomes somehow blue. But then the seizures are pretty short, and the baby will be back to the normal status. Starts to cry, and you can see that this is a pretty well-doing baby compared with a baby with early myoclonic encephalopathy. And then the problem is that 1 hour later, the baby was presenting with another seizure that was exactly a mirror seizure to the first one. So the head is now turned over the left side, and you have left tonic posturing with left arm and left limb hypertonia. It is exactly the same seizure over the other side. Can this be a stroke? No, although there are bilateral strokes. But the baby is doing pretty well, and actually the two hemisoma are involved in the same way. Then the seizures were quite stereotyped and similar in each twin. The problem is they were having almost a status epilepticus with more than 20 episodes per day. However, they didn't need to get intubated, they didn't need to get an IV lines to get fed, and neurological examination in the interictal period was normal in both infants. Seizures were very frequent despite high phenobarbital levels, clonazepam and intermittent diazepam therapy. And then oral Tegretol, carbamazepine was added, and there was no more seizure. In the meantime, all the examinations start, an MRI scan, CSF examination for ruling out infection, organic acid, everything was normal. And then the grandmother came and said, I don't know why you are so worried. My daughter did the same thing as a newborn, and she's doing fine now. So the review of the family history is extremely important, and this is an Italian boy that was having seizures since day 3 of life, and he came in status epilepticus, but again, he was a nice baby. He was treated already with phenobarbital with good levels. We gave him midazolam and phenytoin, and look at the seizure he was presenting. So he had a psychomotor arrest. He had an apnea and was starting to become red, so autonomic component. And then you can see here over the right central region, a seizure starts, and the clinical correlate, over the left central region, and the clinical correlate will be myoclonic jerks over the right leg and then the right limb. So the seizure that will start with autonomic component, psychomotor arrest, apnea, flashing of the face, and then clonic part. And you can see here, so there are 4 on the right, and then 2 left, 2 right, and again on the left. And over the left lead on the central region, you have these myoclonic jerks going on. And then the seizure will stop. And same that the twins. This baby, after a short period with no seizure, will start in the same recording to have an ictal discharge that mirrors the previous one. So it's an ictal discharge over the right central region. And the baby will display in the same recording an identical seizure with the same characteristic over the other side of the body. So this is the seizure going on. And here you have the tonic posturing. Child will have psychomotor arrest, will become actually quite cyanotic, will stop to breathe, hypertonic phase, and then will start to have the clonic phase. You see, it's quite. So these seizures were happening every 5 minutes. So you have the clonic jerk over the left limb that correlates with the ictal discharge over the right central region. So baby seizing a lot, but doing pretty well. Grandma that says, why are you worried? And actually, so this is the EEG. And so you have the first seizure over the left central parietal region that correlates with the jerks over the right deltoid. And then the seizure finish, and you have the other discharge that starts over the right central region and correlates with the left deltoid's jerks. And this was the record of the father of the baby that was hospitalized in our hospital in 1963 with the diagnosis of neonatal seizures. Those 3 babies have benign familial neonatal seizures. Those are age-dependent, autosomal dominant, eye penetrance, focal or generalized seizure. They can present with focal or generalized seizure, usual with autonomic components. We said they have favorable outcome in regard to seizure and neurological development. Some of them will develop benign epilepsy, such as Rolandic epilepsy later in life. And what we found recently is that some patients testing negative for mutation, they might actually display a deletion in the KCNQ2 and KCNQ3 genes. So if a patient is negative for mutation, please look for deletions. And this is a family with deletion in KCNQ2 gene. The grandpa presented with neonatal seizure. You can see that deletion may be associated with longer seizures and with different type of seizure or other than neonatal seizure. This is the mother that was presenting with neonatal seizure and that seizures up to 9 months, and she was treated with valproate. This is our patient. So we got the diagnosis. The mother didn't know before about this family disease. And so this is the first baby that had neonatal seizure plus 3 generalized tonic-clonic seizure at 1 year of age, and he was treated with intrarectal diazepam when needed. This is the second boy, neonatal seizure plus frequent seizure up to 14 seizures per day, up to 8 months, and he was treated with phenobarbital. And Giovanni, which is our patient that was treated with carbamazepine, and he had only neonatal seizure. And when I sit with the mother that was very worried and was asking why you are not doing an MRI, what happened to my children, they are all sick, so I started to explain her that this was a family disorder, that she had the same thing. And the children, she needs to think that the babies they all started to have seizures at 3 days of life. And this was all the same disease. She didn't have to worry. So she looked at me and she said, I understand. There must be something in my milk. Thank you very much. Any question?
Thank you. How useful are you finding the CFM in terms of picking up on seizures? We use it for our HIE babies. We do have access to the proper full EEG, but that takes a while for us to get.
I think it's an excellent tool. and I think we are knowing more and more about it. I think it's very sensitive in picking up babies with seizures, so in picking up the patient. The sensitivity into detecting the single seizure is low, is about 30%, but as a neonatologist, you want to know. So I think it's a good screening tool. And what I usually say is that to me, CFM stays to EEG as the saturation monitoring stays to blood gases. So of course, if you want to make a diagnosis of epilepsy or seizure syndrome, then you need the EEG. But as a screening tool, I think, especially if nurses and doctors are trained for this, I think it's very important because it can be a very good screening tool. No other question? Thank you very much. Oh, yes.
Can you say something about the treatment of neonatal seizures? We had this schema of having phenobarbital, then phenytoin, then the benzodiazepine. Do you treat also the same, or do you use Keppra instead of phenytoin or phenobarbital?
No, at this stage, I think we should have protocols only for subpopulation. So we should have protocols as we have for hypoxic ischemic encephalopathy, so seizures in babies with hypoxic ischemic encephalopathy. In this case, I think, so what we do, we start with benzodiazepine if we are unsure. Then if the EEG confirms seizures, then we load them with phenobarbital. We in Rome only use one dose of 20 milligram per kilo of phenobarbital, and if there is no response, then we move into phenytoin. The important thing is that when you start to treat this patient, you need a monitoring, CFM or EEG, but you need a monitoring because phenobarbital is the principal responsible for electroclinical dissociation. So you don't see any more clinical stuff, clinical features, but the seizures are still going on. So I think I would do that for hypoxic ischemic encephalopathy. At this stage, I think you can wisely try Keppra after phenobarbital, but the protocol, I mean, Keppra at this stage is not approved, but in epileptology, we usually use a lot of treatment that are not approved for children and babies. And of course, if you have a malformation, if you have a tuberous sclerosis, if you have a focal cortical dysplasia, this is an epilepsy, you know already that they will respond to Vigabatrin or to carbamazepine, and they will not respond to phenobarbital.
How do you treat the seizure in the prematures with the intraventricular hemorrhage? They seem also sometimes pretty resistant.
Maybe because not all of them are epileptic seizures, and they are what we call cerebellar fits. So those are tonic posturing, tonic seizure that are due to the blood that goes down into the spinal cord and irritates the spinal cord, and then you have these fits. But most of them are not epileptic if you record them with EEG. That's why they do not respond to antiepileptic drugs. So we'll leave this for Eugenio.